Good afternoon, everyone. My name is Wendy Cromash, and I am pleased to welcome you to this afternoon's Levy lecture. We have a very special presentation coming up, and I know that you're going to be interested in hearing it. Just a couple of housekeeping announcements. First, I want to thank the Levy Senior Center Foundation. Without the foundation, we would not be able to present all the lectures that we've been hosting since April. They have been the backbone for everything connected to the Levy Lecture series, and their help is invaluable. Please keep them in mind when you fill out your, when you make your philanthropic contributions later this year. The second group that we want to thank is Abidor Evanston, the new rental apartment building that opened up in June in Evanston. They are a loyal corporate sponsor and just a tremendous source of support for us. They're located on Oak Avenue. It's a premier rental building for adults 55 plus. They have great amenities, designer finishes, daily events and activities. They have a pool with a sun deck, fitness club, stainless steel appliances and custom flooring in the apartments, and a concierge, daily cocktail sessions in the afternoon. And I know for a fact that they watch the Levy lectures in their movie room. So please give them a call if you're curious about, if you're making if you're considering downsizing. Apartments start at $1,885, and I know that they would be delighted to give you a personal tour. You can call them 847-448-0832. Okay, before I introduce Sumit or Dr. Dhar, let me also say that the hand function I don't have access to it on the way the call is set up. So if you need to reach me, please do it through the Q&A. There are a couple people that have their hands raised, and it's frustrating for both of us that I can't get back to you. Let me introduce you or tell you about Dr. Dhar. He is a doctor of audiology. He is a full professor at Northwestern. He runs an audiology lab that does research. It's called the Auditory Research Laboratory. He's won awards for teaching. He's a mentor to many and guides PhD students. But what endeared me to him were two things as I was preparing for this lecture. All the people listed in his lab, except for Dr. Dhar, are women. And I thought, that is a real man who is able to work and guide and mentor a group of very brilliant women. And the second thing that really I found to be charming is that his title is called Principal Troublemaker. And I think that just points to his great sense of humor and the ability to not take himself so seriously. And without any further ado, I would like to turn the presentation over to him. We will, you will see me on the back end after the lecture is finished, and I'll coordinate answering all of your questions with Dr. Dhar. Welcome.
Thank you, Wendy. Thank you for those kind words. I will share my screen and start sharing my thoughts for today. I should say that yes, it is true. At the current time, everybody in the lab is a brilliant woman. It's men are not excluded from the lab. It just turns out that right now, none of the students or postdocs are men, but had the great privilege of mentoring and actually learning from just wonderful, wonderful women scientists all my life, and I continue to do so.
Excuse me, Dr. Dhar, could you just speak just a little bit more loudly, or turn up your volume, please?
Yes, I will. Is that better?
Uh,
Check. One, two, check. Okay, very good. So please interrupt if this is not loud enough. So the title of my talk broadly today is Hearing Loss, Science and Societal Impact. And I'll sort of outline where we are in the nation today, generally thinking about hearing loss and its impact, and in the first part of the talk. And then in the second part, I'll tell you about 3 projects or 3 sort of research areas that we've been working on for many years now, and how those things impact where we think hearing healthcare in our country should be going or is probably going. So broadly speaking, we work in 2 broad areas in the lab. The first one is termed cochlear mechanics, or essentially is an attempt to try to understand how the inner ear or the cochlea works. This is what I trained in. After I finished my training as an audiologist, I went to get my PhD in sort of experimental and theoretical biophysics. And the area that I started working on is in the biophysics of the inner ear. And specifically in that area, I work on this phenomenon called otoacoustic emissions, which we'll visit later today. This is quite magical. These are sounds that the ear makes while it is listening to sounds from the outside. And we are able to record these sounds and make deductions about how well the ear may be working or not. And then the second area that we work in is in health service or hearing healthcare delivery. This is a newer area in the lab, maybe the last 10 years or so, that we've been working in this area as well. And I'll tell you about a couple of projects in this area as well. So been at Northwestern since 2004, and I would say for the first 6 years or so, I only worked in cochlear mechanics and otoacoustic emissions, and then the lab expanded, and now we have these 2 arms that work in parallel.
Excuse me.
Yeah.
Hi. We've had a couple of other requests to either turn up the volume or speak more loudly, please. And the other thing, I completely forgot to mention this. We are testing a closed captioning service with this lecture. There are a couple people that have requested this, and this is the perfect lecture to see how it works. So on the bottom of your screen, you should see something for closed caption. It's optional. If you'd like to use it, please press it, and then you can let me know afterward how it works. If it's not working, then that means I didn't install it correctly, but hopefully that's not the case. Okay. Sorry for the interruption. Hopefully you won't hear from me until the end.
Okay, I have changed the input volume quite a bit. I'll pause for a second and make sure this is better.
Let's see. Let's see what the audience.
Check 1, 2, 1, 2, 3. Okay, if there are no complaints, we'll keep going. And Wendy, just interrupt me.
Closed captioning. Okay, but let's not wait for that.
Okay, all right. So I'll keep moving forward, and just like this, it's just fine to interrupt and bring something up, whether it's technical or scientific or whatever kind of question you might have. Okay, so let's start by sort of talking a bit about how incredible our hearing is. It's one of the senses that gets activated earliest in the sequence of the activation of senses. The human fetus starts hearing from about 18 or 19 weeks of gestational age. And we know this because you can, for example, do an ultrasound and watch the fetus while playing sounds to it through loudspeakers placed on the mother's abdomen, and you will see the fetus react to sound. Now, what is even more incredible is that the fetus doesn't react to all sounds the same. Here are some results from a study that came out in 2015, and I'll walk you through this graph. What these folks did is they took a large number of children who were born prematurely. And for the time they would have been in the womb, they exposed half of them to sounds of mother's voice and heartbeat, and the other half of them to just regular noises that a child would hear in the NICU. And after the few weeks of this exposure, they measured different parts of their brains. So first, let's look at how parts of the brain that don't have anything to do with hearing fared. In blue are the babies who were exposed to maternal sounds. In red are the babies who were exposed to the NICU noise. And for areas, the RFH, which is the frontal horn, right and left, and the corpus callosum, which is the connection between the two hemispheres, the red and blue bars are statistically similar. However, the right and left auditory cortex areas of the brain that are responsible for hearing and interpreting sound, were significantly more developed in the preemies who were exposed to maternal voice and heartbeat. So not only does the human fetus hear sounds from 18 to 19 weeks, clearly the sounds, some sounds are more meaningful, and especially maternal voice and heartbeat seems to encourage neural development in the auditory areas. So quite remarkable. Then on the other side of things, at the end of our life, hearing persists longer than many other senses. This is also a new finding, and that just came out, and is sort of surprised many of us that even almost after individuals become unresponsive, hearing persists. And we know this from the study that came out in 2020 by Blunden, Gallagher, and Ward. And I'll walk you through this figure as well. It's rather complicated. These are groups of patients from hospice, half of whom at the top of the screen are still responsive, and the bottom half are data from folks who are unresponsive any longer. And what the scientists did is they played sounds to them that changed pitch and changed pattern of presentation randomly without their knowledge. And they record using electrodes brain activity in these red and blue curves, and then EEG or whole brain activity in these colored skulls. The patterns are slightly different between the responsive and unresponsive groups, but what is remarkable is that there is a pattern in the unresponsive group, signifying that these individuals, although otherwise unresponsive, are still registering these sounds. So just like I showed you that the fetus starts hearing very early on in life, it looks like our hearing persists longer than other senses might at the end of our life. Now, what happens in between? In between, we have a really, really incredible sense in how hearing functions. So I'll give you just a few examples. For example, Our hearing mechanism can detect vibrations that are smaller than the diameter of an atom. We almost can hear silence. And while that is really, really impressive, what is even more impressive is that the same system can still tolerate sounds that are 1,000,000 times greater in pressure. So to draw a concrete example, while you are annoyed that the refrigerator at home is making too much noise, that's because your hearing is extremely sensitive and you can pick up on very soft sounds. That same auditory system does not complain when you're standing on a sidewalk and an ambulance goes by with the siren blaring very near you. So this is a really incredible biological system that not only amplifies soft sounds, but also knows to taper that amplification based on what is coming in, thereby allowing us to tolerate or hear a wide dynamic range of signals. That's on the loudness side of things. On the pitch side of things, the intact auditory system can resolve 1,500 separate pitches. And this is without any exclusive or very detailed training in becoming a musician. And so this is a really exquisite system that can separate pitches, help us differentiate notes, much smaller differences than notes. And all of this comes together to give us incredible powers to sort of understand and perceive sound in very complicated environments. And a great example of that is our ability to hear in noise. If you will think about your experiences being in a restaurant or being in a big party or being at a big symphony, and you are able to pick out groups of instruments or an individual speaking to you in the background of many, many, many other kinds of noises and signals. Now, while this is really, really remarkable, what is also true is this ability to be able to pick out signals amidst a background or amidst a cacophony of other sounds is one of the first things that suffers when we start to lose our hearing, even before we can tell that there is a problem by just simple tests of hearing. And we will visit that issue a little bit more later today. Okay, so this is on an individual scale, and it turns out that while our hearing is so incredible, it is also very fragile. And the facts are that 2 to 3 out of every 1,000 children born in the USA has a significant hearing loss. This particular population is not going to be a point of discussion today, but we definitely, that's another story that we can spend time on. Overall, 10% of the US population has hearing loss, has measurable hearing loss. And the number of people with hearing loss grows with growing age. So for example, 25% of those over 65 years old and 50% of those over 75 years old have hearing loss. And the numbers just keep getting bigger and bigger and bigger. So as our population is living longer and living healthier, overall, hearing loss is an increasingly common problem in the population. So today, if you take a snapshot of the USA, there are about 48 million Americans who have hearing loss. Now, this next fact may surprise you a little bit. I know it surprised me when I first found out. Hearing loss is the third most common chronic condition in American adults after arthritis and heart disease. It's more common than cancer, it's more common than Alzheimer's, it's more common than many other health conditions that draw attention to them much, much more than hearing loss does. And as we'll see, and as we make our way through the talk today, that this is changing very slowly, but it is changing for the better. And ironically, it is changing because of the relationship of hearing loss with other health conditions. So, okay, our hearing is fragile, but that's not the worst part of the story, if you ask me. The worst part of the story, if you ask me, is how, as a nation and as individuals, we neglect our hearing. Only 20% of American adults with hearing loss seek treatment. Now that's quite an abysmal number, but that's what the fact is in the USA today. Even those who seek treatment wait 5 to 7 years before doing so. Okay, and this wait is turning out to be more and more critical as we learn more about how the brain reorganizes itself once you have hearing loss and what the side effects of hearing loss may be. And we'll spend a little bit of time talking about that here in just a minute. The WHO estimates that untreated hearing loss costs us $133 billion each year. These are additional costs in healthcare. There is quite a bit of evidence now that if you take two individuals, otherwise equivalent, same education, same socioeconomic status, gender, race, ethnicity, one has hearing loss, the other doesn't. The cost of healthcare for the person, the cost of, and if the person who has hearing loss does not avail treatment for it, the cost of overall healthcare for the person with untreated hearing loss is significantly greater than someone who doesn't have hearing loss or has adequate treatment for their hearing loss. And then on an individual level, if you compared two individuals who were otherwise similar in education, in opportunity, etc., someone getting appropriate treatment for their hearing loss, for example, wearing hearing aids, makes $20,000 more per year than the comparable adult who has a hearing loss but does not use hearing aids. So all of these things put together has shifted our focus, our consciousness about hearing loss and treatment for hearing loss quite substantially in the last few years. And as a result of this shift, big changes are underway. And I'd like to spend a little bit of time talking to you about these changes, and both at the governmental level and healthcare delivery level, before jumping into sort of specific work that is going on in our lab. So whether fortunately or unfortunately, the attention towards hearing loss, or the recent attention towards hearing loss, comes not specifically from the point of view of hearing loss itself, but from all of the side effects, or all of the associations, rather, that have come to be recognized with hearing loss. So for example, there is increasing recognition that individuals with hearing loss experience more falls, more depression, loss of independence, social isolation, ability to work, and then the big one, cognitive decline. It is not clear whether cognitive decline and hearing loss are related as they would be in a cause and effect relationship, but it is very, very clear that there is a very strong association between them. And the big piece of evidence, or big piece of news that came related to this topic came in 2017 in a Lancet paper, where Frankish and Horton documented through extensive search of known facts in the literature of what the modifiable costs or modifiable risks for dementia might be. So I'll walk you through this figure because it's kind of complicated. So if you can follow my mouse, there's this thick bluish line that starts early in life and goes towards the end of life and leads to about 65% of dementia seems to be non-modifiable. in that no matter what you did throughout your life, 60% of it cannot be modified. The other 35% can. So now we can start listing what factors might help influence whether dementia comes on, how quickly it comes on, etc. Early in life, education seems to be a big factor, and that can modify as much as 8%. Or if their education was taken out, it would reduce the risk by 8%, reduce the risk of dementia by 8%. In midlife, you have things like obesity, hypertension, and then here is hearing loss. And looks like if you could remove hearing loss, you would remove 9% of the risk. And then in later life, you have other factors: diabetes, social isolation, physical inactivity, depression, and smoking. Two things to note. One, of all of these risk factors noted, hearing loss removes the most risk, 9%, more than depression or diabetes or smoking. That's quite remarkable, or blood pressure even in midlife. And the second remarkable thing of this finding is that hearing loss is a risk factor in midlife, not later in life, where we have typically associated age-related hearing loss with. So keep this in mind, and we've done some work that seems to validate that where hearing loss is actually happening is in midlife, and we're just not ready to recognize it or not paying attention to it till later in life. So, so this paper really changed how we thought about dementia and how we thought about the relationship with hearing loss and dementia, and it brought a lot of attention to hearing loss per se. Again, like I said, whether it's fortunate or unfortunate, the fact is there is attention and a lot of activity has started, which hopefully will help us identify hearing loss and treat it better. So 4 landmark things that have happened in the last 10 years or so that have changed how hearing healthcare is done or is going to be done going forward. The first one, in 2009, NIDCD, which is a branch of the National Institutes of Health, organized a workshop on affordable and accessible hearing healthcare for adults. I was lucky enough to be invited to that workshop, and that workshop really started a cascade of events where we recognized that accessibility and affordability of hearing healthcare for adults was not optimum in this country or optimal in this country, and needed research input, needed policy input, and all kinds of other input to improve. Then, then in 2015, President Obama asked his Council of Advisors on Science and Technology to study the question of aging America and hearing loss. And they came up with a very, very powerful report that suggested a lot needed to change about how we delivered hearing healthcare in the United States. Right in the footsteps of the PCAST report, that's the President's Council of Advisors on Science and Technology, the National Academies of Science, Engineering, and Medicine took on the subject of hearing healthcare for adults, did a year and a half long study, and provided a report that clearly outlines things that need to be changed for us to do better towards individuals who have hearing loss. And perhaps as the first sort of real policy change following these 3 major events was the 2017 Senate bill called Over-the-Counter Hearing Aid Bill that Senators Grassley and Warren jointly sponsored, and it's now law. The bill asks the FDA to come out with a set of guidelines that would allow hearing aids to be, or allow individuals to be able to get hearing aids over the counter, just like you can get reading glasses. The idea is that this would reduce the cost of hearing aids substantially. So that's where we are policy-wise, and all of these taken together are incredible progress. But there's one other thing that is going on today that you may or may not be aware of. That is, there is a tremendous amount of activity in the pharmaceutical industry to come up with medical treatments, drugs, stem cell therapies, etc., to either protect hearing, stop hearing loss, or restore hearing once there is hearing loss. And here are just a few examples of boutique, small, very fast-moving, new pharmaceutical companies that have been launched with the express purpose of developing solutions for hearing loss. And they are doing very well, raising a lot of interest and capital, making progress. Their work is not mature enough yet to have something close to market, but there are several clinical trials underway, and several of them have quite a bit of promise. So what is the path forward? The path forward definitely includes early detection of hearing loss when it starts in adults, accurate diagnosis, that is now with these different kinds of treatments available, it will not be just enough to say you have hearing loss, but we'll have to be able to specify what kind of hearing loss, what part of the ear is not working, therefore be able to apply the right kind of treatment. And then immediate application of that treatment, and also in parallel, making current options, treatment options more accessible and affordable. So that's where the field of hearing and hearing loss and hearing healthcare is going. So at this point, what I'd love to do is switch gears just a little bit and tell you about 3 projects that are ongoing in our lab that impact these questions that I have laid out directly. So the 3 questions that I'd love to talk to you about first is our question, when should we start worrying about hearing loss? And we've done some work to sort of figure out when the right time may be to intervene. Second, we'll ask, can we communicate hearing test results more effectively than we currently do? And then the third part, we'll talk quickly about what parts of hearing healthcare can be done by the consumer or patient themselves, thereby reducing cost and improving accessibility. So let's start with the first one, when to worry. Before I jump into the results of our study that I'm going to tell you about, I want to orient you to how hearing test results might be presented. So here you see makings of a graph. It's still blank. And along the y-axis here is essentially a scale that shows us how intense or how much sound pressure has to be applied before something is audible to you. And just as a matter of reference, every 20 dB change, this is plotted in dB/SPL or decibels, sound pressure level, every 20 dB change makes the sound pressure 10 times larger. Okay, so if you were hearing something over here today and a year later it has to be this big for you to hear, the sound pressure has to be 10 times greater for you to just be able to perceive it. And then on the x-axis is frequency. So this is what we perceive as pitch. Here are low pitches and here are high pitches in kilohertz. So this is 200 hertz to 20,000 hertz on this scale. Typically in the audiology clinic, if you were to visit one today, hearing is measured from the low pitches out to about 8,000 hertz. And that's great. The problem is that most of all age-related hearing loss starts in the pitches or frequencies that we don't measure. Age-related hearing loss starts at these highest audible frequencies. And by the time you see them at the frequencies we currently test, it may be a little too late for the modern therapies that we are working on today. So you might ask, well, why do we not test hearing at these high frequencies then? Well, instrumentation wise, it is very, very difficult to create a test and create sounds that are reliable at these high frequencies. But we've made some progress that I'm going to tell you about here in just a second. So the next little bit, I'll tell you about a project that is ongoing where my colleague John Siegel, also at Northwestern, and I have built instrumentation and methods to test hearing at these high frequencies and therefore be able to identify hearing loss due to age when it first starts. Okay, so let's show you some results from the study. Here are the hearing thresholds at any given frequency, from low frequencies to high frequencies, in a group of 10 to 14-year-olds. And we will use these thresholds as our reference. Like, this is good hearing. We do not want to lose hearing from here, or we will, but the question is how much. And the idea now is that as we move through these slides, I will put on top of this average hearing thresholds of individuals that are just 5 years older. So these are hearing thresholds of individuals between 15 and 19 years old. And you can already see the black symbols from the 15 and 19-year-olds are slightly higher at many frequencies than the red symbols, which are our reference line for the 10 to 14-year-olds. That means our hearing got a bit worse in these 5 years. And we go farther, not much change from that to 20 to 24-year-olds in pink, not much change 25 to 29 years old, but now 30 to 34-year-olds, we start to see some drop or some increase in pressure needed for you to barely hear a signal at any frequency. And we get to 35 to 39. Again, the line seems to get even higher and higher at 40 to 44, even higher 45 to 49, 50 to 54, 55 to 59, and 60 to 64. Okay, so you might say, well, what's the surprise? We know that hearing might get worse as you get older. The surprise is that we picked these individuals. There's about 975 individuals who are included in this data set to all have what would be classified as clinically normal hearing. Remember, I told you that the current hearing tests measure hearing in the low frequencies, and these people are not very different from one another, even from the youngest to the oldest at these low frequencies. However, when you extend your test to the frequencies where aging is happening, you start to see clear signs of aging. What I'll do now is I'll take the 10 to 14-year-olds or the red line and call it our zero line. This is our baseline. And then I'll plot how much hearing we lose for every 5 years of age as we get older. And this is what that would look like. The zero line is the 10 to 14-year-olds. Then every other line is 5 years older. And you can see that hearing starts to drop quite dramatically right away. And we already have 20 dB hearing loss, which is a clinically significant shift in hearing by the time you're 20 to 24 years old. And the next surprising thing is that you continue to lose your hearing, but the drop is the most significant between this time, 20 to 24 years old, to 44 to 49 years old. In fact, the drop slows down after that. And it's just because we are confined to measuring changes in hearing in these low frequencies that we start to see the effect later in life when the damage has already happened earlier at the base or at the highest frequencies. And then the most we see in our age group is 65 dB of hearing loss in 60 to 65 years old. So this is quite a significant amount of hearing loss by the time you're 60, 64 years old, which has started a lot earlier in life and we just have not noticed it because we have not tested in the right frequency range. But this is not the end of the story. Remember, I told you about otoacoustic emissions, sounds that the ear makes. And this is one of the areas that we specialize in and we measure routinely in the lab. And this is now pretty straightforward. All you have to do is insert a little microphone that is no bigger than a earphone or a earbud that you might use to listen to radio or your phone or whatnot. And we can record these sounds that the ear is making as it goes through the process of hearing other sounds. And we can do the same thing with these sounds called otoacoustic emissions as we did with the thresholds of hearing I showed you before. Again, the blue line here are the 10 to 14-year-olds, and each subsequent line is how much softer these sounds are that are produced in the ear as you progress in age. Now I'll just draw your attention to a couple of things. If you remember the graph from the hearing threshold measurements, you would remember that graph showed a very sharp peak in the high frequencies, whereas this shows a much more widespread decline throughout all the frequencies, and suggests that the ear not only starts to decay for the highest pitches, but across all pitches. And it's simply the fact that we don't have sensitive enough tools yet to understand that this change is happening. So using a tool like otoacoustic emissions, we see damage in the ear that is 5 years earlier than we saw with hearing thresholds, and we see the damage even at lower frequencies. So just for a direct comparison, the traditional method using hearing thresholds and distortion product otoacoustic emissions, the more sophisticated method that we are building on and developing as a test for early detection of age-related change, the first sign of a clinical change is at 20 to 24 years old, 5 years early with the otoacoustic emissions. The rapid drop phase ranges from that age to 44 to 49, 5 years early with the more sensitive test. And then the maximum change is also at a lower frequency for the otoacoustic emissions. So to answer our first question, when should we start worrying? It seems to us that we should not wait till our 60s or 70s to start worrying about hearing loss. We should start worrying in our 40s, if not late 30s. And this early detection will be pivotal for the new therapeutics to be maximally successful. That is, if we truly have a pharmacological treatment to restore hearing, we don't want to wait till much of the inner ear, much of the hearing mechanism has stopped working. We want to start addressing the problem as early as possible so that recovery can be as complete as possible. So that was the first vignette. I'm at 43 minutes. So I'll speed up a little bit so I leave enough time for questions.
Don't worry about it.
Okay, thank you, Andy. So the next question is, how do we communicate test results? And this is work that I do with my colleague, Bruce Lambert, who's Director for Communication and Health at Northwestern, and my very, very promising and bright postdoc, Niall Klein, who has now moved on to a different institution, but did much of this work during his postdoctoral tenure with me in my lab. And this is how this project started. Bruce's mother needed a hearing test. And so we connected her with the audiology clinic, and she came and got a test. And then about a few days later, I got a call from Bruce saying, oh, well, Sumit, what is this? I'm like, what is what? I can't see you, you're on the phone. And he was referring to his mother's audiogram. And the audiogram might have looked like this. This is not his mother's audiogram, I picked one. And he could not make any sense of what was said in this audiogram. This is the de facto tool we use to convey hearing test results. For any of you who've had a hearing test, this would be the test result sheet that you would have been given. And here's Director of Health and Communication who can't make head or tail of it. And I explained what it meant, and he understood, and then he'd call again in 2 or 3 days and say, I'd forgotten what it means, and tell me again. So it got us to thinking, well, does the audiogram do its job? And looking back, we found that the audiogram was built for 3 main reasons: to be the in-house medical record, to be the interprofessional communication tool between different different healthcare professionals, and also the patient counseling and communication tool. So first we said, well, does it work as an interprofessional communication tool? Does it work if I, who did your hearing test, want to communicate your test results with your primary care physician, for example? So here's what we did. We took a very simple audiogram, and we sent it out to 100 MDs currently practicing as general practice physicians, and 60 audiologists currently practicing in audiology, as audiologists in the United States. And we asked them, we gave them a comprehension test, or we gave them a questionnaire to answer questions about this audiogram, and just recorded how they did. Well, here are the results. In red are the audiologist results, and blue are the results of the primary care physicians. Out of a total possible score of 9, the audiologists got about 70% correct, and the physicians got about 50% correct. Now, this is not an indictment of either audiologists or physicians. This is an indictment of how complicated and unrealistic it is that we expect hearing test results to be communicated using the audiogram. So clearly, it's not a very good interprofessional communication tool. Then we wanted to find out whether it was a good patient counseling and communication tool. So we ran a bunch of focus groups with audiologists, with otologists, and with patients and consumers. We asked them about how their first appointment with an audiologist was, what their goals were of the appointment, were there any frustrations, successes, what happened when they went back to one of these physicians or audiologists, and what they remembered of that visit and of the test results that they were given. And we ran these focus groups in hospitals, in private practices, as well as in community centers. What emerged is that professionals, audiologists, physicians, they wanted certain things out of the audiogram. Some didn't use it at all. Others used it as a counseling canvas, in that they would point things out to the patients on the audiogram. They would use it to validate the complaint that the person might have come in with. And in their minds, they were using the audiogram to predict how successful this person might be with some kind of treatment that they might prescribe. Patients, on the other hand, did not want to hear much of that. They just wanted to know, how bad is it? Is it going to get worse? Will a device, read hearing aid here, will a device help? And to some extent, like the physicians or audiologists, predict how successful they might be, mostly with a device. Now, although they could not answer much about what went in the audiogram, they really wanted, invariably, they always wanted to have some token of test results that they could take home. So it was clear that the audiogram, as it was currently used, was not a very effective patient counseling or communication tool. So the question was, well, if it doesn't work, why has it taken us this long to figure out that it doesn't work? Well, once we started looking in the literature, we found this quote in a paper that said, considerable difficulty seems to be encountered in the interpretation of audiograms. And we find out that this is a quote from the first paper that introduced the audiogram, Fowler and Weigel in 1922. So it's not news that the audiogram is hard to interpret. What is really confounding is that no one has done anything about it. And then going back to that National Academies panel that studied hearing healthcare, one of their direct suggestions was that we need to build a consumer-oriented format for audiogram. So Bruce and I embarked on this journey to say, okay, let's see if we can. And after numerous design panels and consulting with experts and getting feedback from individuals with hearing loss, we came up with this alternate, where it's much more simplified. It has 2 bars for the left and right ear that shows how bad your hearing loss may be, and then just 3 pitches. How well do you hear in low pitches, medium pitches, and high pitches, and some words to describe what this means and what the next steps are. And in our focus group testing, this seemed to fare a whole lot better than the traditional audiogram. But being scientists, we wanted to actually do a head-to-head comparison. So we took the traditional audiogram and our new sort of infographic, and we sent it out to be tested by assigning one or the other randomly to individuals, asking them to study it, and then asking them some questions about what this hearing loss might mean after reading the infographic or the audiogram. So this is a 10-point test, and we gave the test to about 165 individuals in and around Chicago. And as we expected, the original audiogram did not fare better. The mean score was 5.8 out of 10. And here I'm showing you the scores divided into 3 categories for those with limited health literacy, with moderate health literacy, and with adequate health literacy. We had imagined that those with limited health literacy would have greater difficulty with the audiogram, and you see a slight trend, but the main thing to notice is that there's great variability in comprehension in those with limited health literacy. So this kind of showed what we were suspecting, but to some surprise, even those with adequate health literacy did not understand everything that needed to be understood from the audiogram. Now here comes the bad news. The bad news is, yes, the audiogram is pretty bad, but our new infographic is not much better. Okay, in fact, the mean score dropped just a tad from 5.8 to 5.7 using our prototype. We see a little bit of gain in the moderate health literacy group, but otherwise this audiogram does not perform, or this new infographic does not perform much better than the old complicated graph. So we are disappointed, but we have not given up because it's clear that there's much room for improvement, but the right format is difficult to find. So we have relaunched this design phase, tweaking some things to make sure we arrive at a different endpoint with this round of redesign. And hopefully we'll come up with something that's easier to comprehend and remember here in the near future. And the last project that I want to quickly tell you about is, well, how much can hearing healthcare be done through self-help? And remember, I told you about the National Institutes of Health workshop that started it all in 2009. And there the focus, or the idea, was to discuss, well, what comes between hearing loss and hearing aids? And people identified a lot of different barriers that are in the way of hearing aids. But one of the barriers that was identified is this FDA regulation that doesn't exist anymore, called the medical clearance. And I'll tell you just a little bit about it. Till about December 2017, if you had a hearing loss, got diagnosed that you have a hearing loss and you could use hearing aids, you were asked to go get a medical clearance from a ear doctor or laryngologist to say that you did not have any other kind of disease that needed treatment first before you got hearing aids. And according to many, this was an added cost. It was a loss of time because you'd go find an appointment, get the medical clearance, etc. But what was even more paradoxical is the FDA also gave you the option of signing a waiver. And say, okay, I know I have a hearing loss. I really don't need a medical clearance. Go ahead, fit me with a hearing aid. So both of these systems existed. No one really knew how much one was used over the other. So after I came back from this came back from this workshop, I thought, well, how big is a problem? How big is the problem that we are tackling here? And what I did is I went through the literature, anything I could find, and tried to account for the number of people who, over the age of 50 in every million, who would have age-related hearing loss, nothing else, versus all of these other diseases that would require a medical clearance. And as you can see, compared to over 500,000 of the 1 million people over the age of 50 who might have hearing loss, the other things are minuscule. And this 20,000 is earwax. It's not a, like a tumor growing in your ear or something like that. So with that being the case, my thought was, well, why is the system funneling everyone through a process that is expensive, time consuming, to detect very small numbers of these other diseases? Is it possible that the patient or the consumer themselves can do this diagnosis, or at least do a risk assessment themselves? So we came up with a project that was funded by the National Institute of Health, and we did in collaboration with the Mayo Clinics. We first figured out which are the diseases we need to worry about. How does a physician screen for these diseases? What kinds of questions do they ask? Can those questions be answered by the consumer without a physician involvement? And if they can be, could we design a questionnaire to give a person their own risk of ear disease? And out of that process, about 4 years long process, came this instrument called the Consumer Ear Disease Risk Assessment, CEDRA. And it's a 15-question questionnaire. You say yes, no to a bunch of questions. For example, we would ask you, have you ever noticed pus, blood, or other active fluid discharge from your ear? Yes or no. Some questions are a little more complicated. How often do you have dizziness? Never, occasionally, frequently, always. So 15 questions like those. And then you add up every yes, or when it's a yes, no question, and some other scoring if it's a multiple choice, and you get a CEDRA score. And if your CEDRA score is 4 or higher, there is a high risk you have some disease other than just age-related hearing loss, and you should go see a physician before getting hearing aids. If not, the chances that you have ear disease are very, very small, and you should have some confidence in signing this waiver and getting hearing aids directly. And when we tested the questionnaire in a group of 635, first in 300 some patients and now in 635 patients, we can correctly assess the risk for ear disease in almost 90% of the cases. So here's one example where we can simplify hearing healthcare delivery, tremendously saving time, money, and resources. So our paper came out in 2017, first describing this questionnaire, and I'm so pleased to report that the FDA no longer enforces this medical clearance before hearing aid purchase. And CEDRA this questionnaire is included in many clinics for their intake. It's also available to everybody for free at cedra.northwestern.edu. You just go there, take the questionnaire yourself, and it gives you a risk score. So what parts of hearing healthcare can be done by the consumer? Many parts of the hearing healthcare delivery system can be made more efficient. So the good news is that new tests, new treatments, and efficiencies are under development. But then the last question that we have to tackle is, what about the here and now? Well, the here and now is that if there are 30 million Americans who could benefit from a hearing aid, only 21 million go talk to a doctor, of which 8.5 follow up with the hearing screening, 6 million buy hearing aids, and of that, 5 actually use them. So we are losing people along the way, and different kinds of tools are necessary to make sure we don't lose folks along this chain of hearing healthcare delivery. And the fact is that if you have hearing loss of certain magnitude, you will benefit from using hearing aids. And it's not just empty talk anymore. There are studies beginning to emerge where if you take normal hearing individuals and study brain activity for different kinds of sound exposure, you see how focused brain activity is. And then you do the same experiment on individuals with hearing loss, you see that in many areas, the brain activity gets more diffuse because of the hearing loss. But then if you put hearing aids on these folks and test them again 6 months later, you see that the brain activity has become refocused, much like the normal hearing brain. So there is emerging evidence that even a little bit of hearing aid use can reverse some of the plastic changes that happen in the brain due to hearing loss. So the last question then is, well, can we reduce the cost of hearing aids, as is the goal of this Over-the-Counter Hearing Aid Act? And will the reduced cost of delivering hearing aids be as effective as it is given today's way of delivering hearing aids through audiologists and physicians? We don't know the answer. There are a couple of early studies that have come out, but we are launching on December 1st nationwide 4-site nationwide study to test exactly that. We will fit individuals with hearing aids in multiple ways, using the over-the-counter methods as well as traditional methods, and in 6 months' time, measure whether the outcomes are the same or different. And we hope to be able to inform healthcare systems and policymakers about the effectiveness of these new techniques. So today what I've tried to tell you is that hearing loss is a major healthcare concern nationally, and early detection and treatment are pivotal. And the timely treatment of hearing loss has the potential of mitigating the many ill effects of hearing loss. Thank you so much for attending today, and I will stop sharing my screen and would love to answer some questions.
That was so fascinating. Let me just, okay. Lori would like to know, what is the definition of hearing loss?
That's a very good and important question. So most statistical studies that policymakers use a measure of hearing loss that is derived from the basic test of hearing, where you go in and you're asked to raise your hand or press a button when you hear a tone. And it takes the average threshold across 3 frequencies to give you a number. And let's say your average threshold at those 3 frequencies is 25. You are designated a category of hearing loss. Typically, 20 and below are normal hearing. Above 20, you start to perceive or you're categorized to have hearing loss. As the number gets bigger, you are mild, moderate, moderately severe, so on and so forth. But there is increasing recognition that just hearing those tones is not what hearing is about. And understanding speech and background noise, picking out symphonies or particular instruments in a big symphony, or things like that, more complicated tests, are the essence of hearing. So there are systems in place in other nations and even here that are going in 2 different directions. One direction is to actually test your ability to understand speech and background noise. So for example, many European nations have hotlines now where you can call and you hear digits in background noise. And you have to press on your phone what digit you heard, right? And based on whether you got the right digit or not, it makes it harder or easier for you. And based on that result, which is very different from raising your hand to a tone, they classify you to have a hearing loss or not. Similarly, there is a movement to go towards self-report. There are standardized questionnaires that have been developed and under development, where they ask you questions about specific situations and the amount of difficulty you have in hearing, and assign you a score and then classify you as hearing loss. So those are the trends that are moving us away from the raise your hand and I'll calculate the average hearing loss for you. Now, this Over-the-Counter Hearing Loss Act, or Over-the-Counter Hearing Aid Act, is very interesting in that it says this category of hearing aids is for individuals who self-perceive to have mild or moderate hearing difficulty. So it divorces itself from a medical test of hearing where you're assigned a number and categorized a hearing test or a hearing loss category. So for the study that we are launching, we are advertising for individuals just like that, who self-perceive to have mild or moderate hearing difficulty. We'll do a test on them, see where the actual test results fall, but that does not qualify or disqualify you from the study. What qualifies or disqualifies you is your self-perception of how much difficulty you may be having. So unfortunately, there's not a straight answer. The answer even 5 years ago was that, oh, you got to go take a hearing test and we'll calculate this average and give you a number. But with time, as we are recognizing the complexity of hearing, we are moving away from that strict definition of hearing loss.
Okay. Janet asks, are there any studies on how diet affects hearing loss?
There are small studies that show beneficial effects of diets that are essentially consistent with good cardiovascular health that also seem to help hearing a bit. The big news that related to this is we do a national survey of hearing called the as part of the National Health and Nutrition Examination Survey, where thousands of people are tested every year by the Census Bureau for hearing, amongst other things. So it's possible for us to go back, compare our nation's hearing from today versus 30 years ago, 40 years ago, 50 years ago. When we do that, we see that our hearing today, say in 40-year-olds, is slightly better than it was in the 60s and 70s. And that is ascribed to primarily two things. Occupation in the US has changed dramatically is one major thing. But once even we control for that you can control for by accounting for noise exposure, there still seems to be a little bit of improvement in overall national hearing. And most people who study this are ascribing this to improvements in diet, cardiovascular health, etc., and overall health.
That's so interesting. Do you see differences in different countries?
Yes, this study has not been systematically done in a while now. And one reason is that different aspects that might affect hearing are getting sort of segregated between post-industrial nations having some kind of exposure and health and diet and all of that versus industrial developing world nations having a whole different set of circumstances. But the classic study that everyone refers to is one from the late 50s, early 60s, where a physician from New York went in to Africa and found a tribe in Sudan that had remarkable cardiovascular health. Almost no incidence of high blood pressure, mostly plant-based diet and no noise exposure, obviously, and showed almost a 30-year difference in how much age affects aging. So someone who is an 80-year-old in the Sudanese population heard as well as a 50 or 40-year-old in the American population. And that was, some of it had to be genetics, but it was, a lot of it was noise exposure, diet, lifestyle. And that people have replicated parts of that study, but it's getting increasingly more difficult to do because lifestyles are very similar across the world today. And it's very hard to find such dramatic differences that you can draw a clear line and study the two populations and draw clean conclusions from.
Okay. Penny has a comment about a comment and a question about the high cost of hearing aids. Is it surprising that the population making more than $20,000 a year are the ones wearing hearing aids?
That's I see your point. Luckily, the authors of that study equated socioeconomic or income between the comparators, between those who were wearing hearing aids and those who weren't. So it was not entirely driven by who could afford and who couldn't afford hearing aids. But your point is very well taken. The utilization of hearing healthcare is very heavily skewed towards higher income groups in our nation. And unfortunately, that is very highly correlated with racial and ethnic boundaries as well. So for example, if the uptake of hearing aids is 20% in white Americans, it's half of that at best in Black and Mexican Americans.
Okay. Marcia has a question. When my dad died in 1987, I was told that his hearing might still be working. Did we know anything about that back then?
What year was that again?
87.
No. The fact that hearing may still be operational at the end of life is a very new finding. Now, there are anecdotal reports of individuals in coma who don't respond to anything but respond to a familiar person's voice, and we know all these stories. They're part of movies and stories and all of that. But the scientific evidence that I shared with you today is recent and is probably the first direct evidence that not only is sound going through the ears, it is arriving at the brain and registering as sound in the brain.
Okay. Ed would like to know, what years are you calling midlife?
So the Lancet survey called everything between, I believe, 20 and 60 to be midlife. In our work, we do see that hearing starts to decay pretty rapidly from the mid-20s all the way to the mid-40s. So that's where we think the bulk of the drop is happening. It's happening in frequencies that we haven't cared about before because they're not, essentially because that's not where speech energy is based. But now we are becoming aware of them, becoming concerned about them because we want to use them as the early signs or the early symptoms of hearing loss so that we can trigger treatment based on those rather than the late signs.
Okay. Lori would like to know, what are the major causes of hearing loss?
For age-related hearing loss, the topic that we're talking about today, the name would suggest it's age, but it's not just age. So a bunch of it is noise, and we traditionally used to think noise is only dangerous or harmful when we are exposed to concerts or industrial noise and whatnot. But there seems to be evidence that just day-to-day exposure every day, uses up, so to speak, our ears. And many of us who work in this area are beginning to understand or believe that our ears were just not made to last as long as we last nowadays. We just essentially use up our hearing before our time is up anymore, as life expectancy has gone up. So it's a mix of everything. It's a mix of just pure aging, but also a mix of exposure to environmental sounds. There are lots of medications, chemicals around us that are toxic to hearing. Some in the extreme, like some cancer treatments, are known to cause hearing loss immediately, but we are also aware of other chemicals and other things in our environment that have a slow but still a deleterious effect on our hearing. So ultimately, it's a mix of all of this. The proportion of all of these causes on any given individual is different, but the bulk would be exposure to daily listening sounds, which act as noise damage to our ears, and the regular process of aging and losing just body function.
Do earbuds affect hearing loss? Shari would know.
Ask that one more time. Do
earbuds affect hearing loss?
Yeah, so this is a very controversial question. I tell my children they do. So, different people have tried to study this objectively. And, the notion that earbuds are dangerous come from observations such as you can be on a train and you can hear someone listening to their earbuds, 5 feet away or 10 feet away. And you're like, how loud is this in their ear? When people have tried to actually measure how loud something is at people's eardrum, turns out most people self-regulate very, 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 very well. Very few people are turning the signal up so high that it's outright dangerous for them. So that might suggest, well, it's not so bad. But what is different is that the duration of listening through these earphones is dramatically different today than it was even 10, 15 years ago. One is the size of the device. The second is the battery life of the device. And the third is how much music you can have on it. So you could have music on all day, every day and not run out, which was not possible before. So overall, it probably is not a very healthy practice. And there are general guidelines out there, like no more than 80% of the volume, take a break every 60 minutes, so on and so forth, and many public service announcements surrounding that. There are even devices that people have built that are inline. You can put in between whatever your player is and your headphones, and it tells you how much time you have left for today, what's been your dose of listening for today. And once you get to 100%, you should turn it off. Empirical evidence suggests most people listen to it at moderate levels, not dangerously loud levels. But the duration and the accessibility to this exposure is of concern. There are studies that are beginning to emerge that are comparing hearing of teenagers today versus hearing of teenagers prior to these devices. And most of them show a slight trend towards worse hearing for teenagers today. The real effects we'll find out once these folks are 50, 60 years old.
Wow. Marcia would like to know, how does sensitive hearing affect autism?
Very unclear what the connections are. It is not uncommon to have individuals on the spectrum to be hypersensitive to sounds, but as we know, individuals on the spectrum can be hypersensitive to all kinds of senses, not just hearing. But I'm not an expert in autism, but this much is for certain, that the spectrum is so broad now that it's hard to sort of make any specific comments about the connection to hearing, but there certainly is a subpopulation where hypersensitivity is an issue.
Okay. Two comments. 11 address you. If you need to reach me, please use the Q&A. And also, we've gotten, some people are submitting medical type questions, which I'm not going to ask Dr. Dhar because it's just not the right format. How can people learn about advances in hearing aids, such as noise canceling models, and also the pharmaceutical advances that you mentioned?
Yeah, so that the pharmaceutical advances are a little harder. Let me talk about those first. So there are a multitude of these boutique new biotechnology companies that are investing a lot of energy in trying to find solutions. Some are more advanced than others. The difficulty is that it's still in the hit and miss kind of phase. So till we get a more stable solution, till we get through a couple of good clinical trials and know something's going to work, it's hard to pin our hopes on something being immediately effective. I would say a good place to keep an eye on is the NIDCD website, National Institute for Deafness and Other Communicative Disorders. This is a branch of the National Institutes of Health. They have updated information about treatments for hearing loss. You will, I mean, this is a big deal. When something really hits, it'll be all over the news. It'll be New York Times and whatnot. So we haven't had that big hit yet. We keep getting glimpses of, promise, but soon something will happen. As far as hearing aid features go, there's a new feature every day. There's a million things that you can purchase and whatnot. Again, I would say the NIDCD website is a good place. There is another website I really like called Hearing Tracker, hearingtracker.com. That is a website run by an audiologist, but it seems to have like a consumer's point of view in mind, where it compares features, it gives reviews, etc. And people who have used the technology can go make comments, etc. But at the end of the day, there really is no substitute in finding, good professional help, be it from your ENT doctor, be it from your audiologist. Audiologists are really well trained and they know a lot about what's going on with hearing aids today. So ultimately, if you're not certain about what features, etc., I'd trust a professional to guide you.
Okay. I will, when I send out the follow-up email after the lectures, all attendees receive that. I will include links to all of these different websites that Dr. Dhar is mentioning.
Thank you.
Are mail-ordered hearing aids any good?
Don't go there.
Okay.
There's some may be good. It's hard for me to tell because there's a new one every 3 hours. And so I can't really tell you anything that will be true for the next 4 hours or so. In general, if you can avoid them, avoid them.
Okay. At what age should a person's hearing be tested and how often?
It's a very, very pertinent question. So, there's been quite a bit of movement to try and see, well, should it be part of your annual physical check? And when should it start, or how often should it happen? And so far, there has not been a definite answer. So the task force, the national task force that decides what goes into the annual screen, has avoided adding hearing test into the annual physical. And as it is, the annual physical is so chock full of stuff, starting from your health to whether you have batteries in your smoke detector or fire detector or not. It's hard to pack anything else in it. I would say in the 50s for sure, if not earlier, it's time to get a good check and get a baseline so that you can track your hearing. But also listen to your hearing, so to speak. So one of the things that happens with hearing is we are able to modify our environment to suit our hearing, right? So we can turn up the TV. We can stop going to the noisy restaurant. We can get together with 3 rather than 7 friends. So gradually, as our hearing starts to decline, we adapt our lifestyle to accommodate the hearing loss. Therefore, we don't have a hearing loss anymore, right? But if you're aware that you're making these modifications, you will know that something is changing in your hearing. And then in the places where you should start to notice difficulty are when you're listening to one person in background of many people speaking, like at a party or at a gathering, or in a large hall like a church or a seminar room or something like that, and you're not that close to the speaker anymore. Those are the early signs that something is starting to change, and that's a good time to go get a hearing test.
Okay. Jeff asks, could you give examples of the sounds that you would not hear at the higher frequencies?
Yeah, that's generally speaking, what people will say is grandchildren's voices, female voices, another example. But the very eye-opening thing is what people start to hear once they get their hearing aids, right? And it's not uncommon for audiologists to say, we very commonly hear, I went on a walk and when I step on leaves, they crackle, right? Or that the radiator in my basement hisses, or that there is this annoying sound that my wheels in the car are making, right? And it's like folks who are in hearing healthcare say that they're the best thing that ever happened for the car care business, because everyone who gets hearing aids gets back in their car to drive home, notices all these things that are wrong with their car because they did not hear the noises before. So generally speaking, high-pitched sounds are environmental sounds that some machines make. So things that are turning, bearings, and things of that nature. Appliances often are sounds that you stop hearing, and your house is more silent than it was when you could hear them. And as far as other noises, other sounds go, music may start sounding more blunt in that you've lost the high register of sounds. So the brightness of the music gets reduced. And also some instruments become harder. The flutes and things of that nature that are higher pitch become harder to hear. So those are some examples to keep an eye out for.
Okay. Are there remedies for tinnitus?
Tinnitus, yeah, that's a hard one. So every time you look, there seems to be one new cause or one new pathology associated with hearing loss or associated with tinnitus identified. So really, there are no known, one remedy for everything. There are sort of behavioral therapies that people go through. There are sound therapies that people go through that seem to sort of help you suppress or deal with your tinnitus better. It turns out tinnitus has become such a specialized thing to understand and treat. I don't understand much of what's going on with it now. So, but I know this much to say that if someone tells you, doesn't matter what kind of tinnitus you have, doesn't matter how you got it, here's something that works for it, that probably is an overgeneralization, because there's a little more nuance to that.
Okay. Karen has a question about the questionnaire that you talked about. So if the person fills out a questionnaire and it's determined that there are no other serious medical issues,
correct,
are you saying that they can buy a hearing aid over the counter without first going to an audiologist?
So the two things, the over-the-counter hearing aids are not available yet. So the law has asked the FDA to come up with guidelines, and once they do, companies will make hearing aids that fulfill those guidelines, and they'll be available one day. And we don't know whether the FDA will say you have to take this questionnaire or that questionnaire, what they will say en route to an over-the-counter hearing aid. When we made this questionnaire, the medical clearance before hearing aids, even from an audiologist, was a necessary step. And this was a tool that was designed to give the consumer some confidence as to whether they should go get a medical evaluation or they should sign, or they could reasonably sign the waiver and go directly to get hearing aids, no matter from where. Now, in the changed landscape, now when hearing aids are available on the over the counter, we would hope that this and other tools like this would be useful, and it would help people decide whether this is the right branch for me or whether I truly need to go see a physician or an audiologist. Because one of the sure shot ways of this over-the-counter reduce the cost movement to fail is if those who can't benefit from those devices end up trying them and they're not successful, and that the whole process fails in the regard. So the idea is to build methods, build tools that help the consumer guide themselves to the right spot. So they're getting the kind of treatment that they need without wasting time and money in other things.
And that would also include hearing aids that don't fit well or that aren't adjusted well, because some people give up after.
Correct. Absolutely. So that's not our questionnaire, but we'd hope there would be similar tools that would say, well, it's not your hearing, a different device or a device fit better would help you. Absolutely correct.
Joel asked, does every older adult lose their hearing as they age?
Well, ultimately, yes. But for example, 75 years and older, about 50% of individuals have significant hearing loss. And the percentage just keeps getting bigger and bigger as we age. And so the question is interesting in many ways, is why don't some people lose their hearing and some do, right? So the easy answer is a bunch of it, maybe lifestyle, noise exposure, diet, all that kind of stuff. But there is a movement in place to study what people are calling super hearers, so the people who can preserve their hearing. And are there protective genes in place? Is there something about their biological constitution that helps them keep their hearing longer? At the end of the day, it's probably not any different from why someone at a certain age is physically more able than someone else, and so on and so forth. But the biology of it, if we can unravel it, would be very helpful in figuring out what to do for those who are on the other side, who are getting hearing loss with age.
I've read that dogs hear much more than humans do. The decibel range, is that due to the structure of their ears, and that's something that would be impossible for us to ever get to?
Yeah. So what you're talking about is the pitch range over which they hear. So the idea of the dog whistle that you can't hear, but the dog can, because it's at a pitch that is inaudible to the human. So, all different animals have different ranges of hearing, and different evolutionary pressures led to either limiting or expanding the range of hearing that each species has. And it is indeed the case that dogs hear over a wider frequency range than we do. The extreme examples are some whales and bats. These animals hear out to 100, 150,000 hertz. So it's 4 or 5 times bigger than wider range than humans. On the other end are birds that only hear 4,000 or 5,000 hertz, which is a quarter of human hearing. So yeah, different animals have different ranges. Hard to tell what evolutionary pressures led to those ranges.
Are there dangers of hearing damage due to inappropriately programmed hearing aids?
It's a very good question. I can't say no, there is no danger at all. What I do know is if you get fit from a person who's licensed to dispense hearing aids, or you get hearing aids from a reputable organization, the risk should be minimal. These hearing aids are built with automatic output limits. Every hearing aid today has very, very sophisticated technology that limits how loud anything can get in your ear. Now, is it possible to fit you with a mild hearing loss but fit a hearing aid that's meant for someone with very severe hearing loss, yes, but that would be a gross error on the part of the person who's fitting it. So when hearing aids are fit to your hearing loss, the chances of them damaging your hearing farther are minimal, if any.
Okay. We're at 2:30. How are you doing for time? And okay, great. And people, just remember, if you have another obligation, you are free to leave the webinar. It will be posted up on YouTube probably by tomorrow, and you can, catch up for whatever you didn't.
Yeah, and I'm also happy for folks to email or ask questions later. So.
Be careful. Are you still recruiting for a hearing loss study?
At all times, we have studies ongoing for different purposes. The big study that is the trying different ways of fitting hearing aids launches December 1. So we're waiting for final approval from the university to start recruiting for that study. But there are other smaller studies ongoing in the lab that we're always recruiting. Our website is hearing.northwestern.edu. And you could go to the website. It has a link that tells that if you want to participate, you can put in your contact. We'll get in touch with you.
Okay, great. And I will include that URL when I send the follow-up. Does wearing a hearing aid slow further deterioration of hearing?
That's a very, very, very good question. There is no clear-cut evidence to suggest it will for everybody who puts on hearing aids. What is starting to become evident is it changes other things. For example, there's just a new study that just came out, which is showing that post-wearing hearing aids, the test scores on some cognitive tests improved. And now the simple answer to that is maybe they just could hear the questions being asked this time around than the last time around, but I don't think it's as simple as that. The outcome or the hearing outcome of wearing hearing aids probably changes based on what kind of pathology it is that you first came in with. There are certain progressive kinds of hearing loss that are hard to slow down or curtail. But what is important is, even though the measured hearing loss may not slow down or may change, what would definitely change is how well you can use sound, because the more you expose your brain and the entire nervous system to amplified sound and sound in general, the better it is for the kinds of reorganization that we are starting to see in the auditory system. And that then affects other parts of our function as well.
Okay. Can hearing aids help in situations where your hearing was damaged as a child?
Can hearing aids help in situations where your hearing was damaged as a child?
Say by a loud noise.
Yeah, it depends on how bad the hearing loss, the resulting hearing loss was. So depending on how big the hearing loss is, there are different kinds of treatment. So in the extreme, when there's a lot of hearing loss, today the treatment includes or involves cochlear implants. This is a surgically implanted device that stimulates the auditory nerve directly, bypasses the ear, so to speak. But that's when there's a lot of hearing loss. For less hearing loss, hearing aids are still the treatment of choice, provided there is not a medically treatable condition. For example, if you experienced a blast and it blew open your eardrum, well, the eardrum needs to be surgically repaired first. So those things taken care of first, then you still have a hearing loss that does not have a medical or surgical treatment. Yes, hearing aids would be the right place to be.
Okay. Robert has a question, since we were talking about children. How will our children's hearing be affected going forward with the advent of all the hearing amplifiers and devices on the market to enhance sound? Will our kids be needing hearing aids sooner And will the stigma of wearing hearing aids disappear?
Yeah, let's talk about the stigma first. Of course, there are more people with things in their ears today than there ever were, right? And so you'd think that it would reduce the stigma of wearing hearing aids going forward. In reality, also, though, hearing aids have become virtually invisible, right? So these behind the ear hearing aids nowadays, they have a little thin wire that goes in your ear. I can't tell anymore when someone's wearing a hearing aid. They're so small. There are other solutions that are being developed where the hearing aid is all the way in the ear and doesn't need to be taken out for months. They're not for everybody, but for some. So the stigma, I think the hearing aid manufacturers are working hard to reduce the visibility, but at the same time, maybe having something in your ear is becoming more and more acceptable. Now, whether current lifestyle ends up causing more hearing loss or not, certainly more exposure to loud sounds is known to lead to more hearing loss. The remaining question is, are the people who are using these devices today abusing their hearing to the extent that it causes more hearing loss going forward? The answer is mixed. Nonetheless, it can't ever hurt to follow some simple guidelines of how loud something can be, how long you can hear for during every 4 hours or so on and so forth.
Shirley has a question. Just to confirm, did you say that not treating hearing loss has a cost in brain function?
Well, so again, I don't want to say one causes the other, but there is a very strong association. So study after study after study is starting to show that those who have hearing loss but don't get treatment have more cognitive decline with age as compared to those who don't have hearing loss. And now there is a study that is underway in Baltimore, where a large number of people are volunteering to either wear or not wear hearing aids when they start having hearing loss, and they're following their cognitive function to see whether putting hearing aids on actually slows down the decline of cognitive function. So we'll find out soon.
Are there studies that relate attention span and concentration to hearing?
That's a very, very good question. So there is quite a bit of work that zeroes in on this topic and focuses on what people call listening effort. It's the amount of brain power that you have to expend to hear during the day when you have hearing loss. And it is significantly greater than you have to when you don't have hearing loss. And people have come up with ways of measuring listening effort, etc. And it is now very, very obvious that when you have hearing loss, you are expending much more cognitive energy to try and understand what's going on around you compared to when you don't have hearing loss. And that results in things like towards the end of the day, even though you can hear someone speak, you don't want to expend the energy, or you don't have the energy to expend to try and understand what is going on anymore. So that's one other sort of nice variant to this line of work, where the idea is what kinds of treatments reduce this listening effort in people and give them more prolonged listening throughout the day.
Okay. Bobby asks, what is the success rate of cochlear implants in children born with hearing loss?
It's miraculously high. It really is quite astounding. Cochlear implants are by far considered the most successful neural prosthesis ever invented. And to the point where now we are operating and implanting children very early on, before they're 2 years old, before they're 18 months old, and getting really, really awesome outcomes where the children are integrated into mainstream schooling. They're part of their class of their hearing peers. And it's not uncommon for us to have folks in our graduate programs with cochlear implants, which, when I started in this field, it was, if you had that much hearing loss, you went to a deaf school, right? And unfortunately, the outcomes at the end of deaf school were not as good as they are in a regular school. So it has completely changed the landscape of how children fare with hearing loss.
Okay. Diane would like to know, are there consequences of wearing a hearing aid 50% of the time rather than 100% of the time?
I wish I knew the answer to that question. So one of my PhD students is really, really interested in the answer to this. Is there a right dose, is the question you're asking. We think that anecdotally, at least, more is better than less. But again, what we hear from people who wear hearing aids is that, at least initially, after they first get hearing aids, it becomes too much after a few hours a day. And I believe it's partly because the brain now has to register a lot of different acoustic input that it was not used to or did not have to deal with before. And the practical answer to this is maybe you should stop when you can't stand it anymore and start over the next day. But I wish I could give, and the field needs to know the answer to your question, Diane, and that what is the right dose, and should it change with time? Should it be different for different amounts of hearing loss, et cetera?
But in the example that you just cited, is it, would the hearing aids or the implants be kind of, I don't know, like working out your ears, and that you wouldn't work out for 8 hours a day? You'd have to build up to it.
Absolutely. And it's not uncommon for people who wear hearing aids to say, I actually look forward to turning off my hearing for 2 hours a day or 3 hours a day or whatnot. And sometimes I wish I could. But again, all of that is anecdotal. We need evidence to sort of figure out what the right dose is.
Okay. Linda says, there's hearing loss throughout my family. Well, I had a small loss. It became much worse after a severe bout of red measles. I am now completely deaf and had a cochlear implant 4.5 years ago, a true miracle. Is there a way to trace potential hearing loss prior to birth, during pregnancy?
No, I mean, it would be possible to trace it. I mean, there are clear genetic markers that would tell you that there's a high chance that someone would have a hearing loss. It's possible to test whether a fetus hears or not. Like I said, it's not very difficult at all. You do an ultrasound, you put some speakers on the mother's belly and you play some sounds, and you notice the fetus react to those sounds. But other than some genetic conditions that may come out as part of other tests, no one cares to do the test except for when there is hearing loss in the family. So it's not uncommon for families to go through genetic counseling, through other, all kinds of test batteries, when there is a good chance that there may be hearing loss in the family. So yes, it is absolutely possible to figure out, but there's no reason to unless there is reason to.
Okay. Are hearing aids different? Are there differences in hearing aids? Are some just volume boosters? And
absolutely. So I mean, if you went to an audiologist or a physician's office, the chances are you're not going to get a hearing aid that's just a volume booster. These are very, very, very sophisticated instruments today. But there are some out on the market. Yeah, absolutely, I see ads in magazines and whatnot that are for bird watching and this, that, or the other, or miracle ears and whatnot. And
they've gotten better over time.
Yeah, the regular hearing aids have become really, really high-end, sophisticated instruments. And the real question is, can we use all that sophistication to better our hearing today or not? But I would say if you have any doubt whether you're getting what would be a modern hearing aid, go to a professional. There are, not many, but a handful of very good companies that are, manufacturing and producing really high quality hearing aids.
Robert asks, how close are we to legislation that allows the majority of insurances to cover hearing loss? They do it in Europe.
Yeah, very far. But the good news is that we are seeing pockets of insurers starting to cover some hearing aid, and it's coming in different forms. Some insurance companies or some insurance plans are giving a certain number of dollars for every so many years towards hearing aids. Some insurers are saying, we'll cover 50% of a pair of hearing aids every 5 years or so on and so forth. But it's a growing recognition that if you want the aging American population to be your client, you need to care for hearing, because everybody is having to deal with it. But it's spotty. It's still pretty spotty.
Okay. Jackie asks, does hearing loss in individuals cause balance issues? And if so, how?
Yeah, so causes, I don't know whether it causes or not, but there clearly is a lot of evidence to suggest those with hearing loss in their older ages also have more falls. Again, those with more falls also have more hearing loss. And there is quite a bit of work underway to figure out if it's a direct link or not. So for example, if you could remedy the hearing loss, would the falls go away? It's just the beginning, but the early signs are that it may have an effect. I don't know that it would totally, eliminate falls or balance problems, but it would impact them positively.
Okay. Can noise canceling headphones or white noise machines be harmful?
Again, the loudness with which they are played. Noise canceling headphones should not. So the way the noise canceling headphones work is they essentially can phase cancel low frequency signals like you would wear them on an airplane and you don't hear the airplane anymore. So that by nature should not change should not have any effect on your hearing. A white noise machine that you might use to fall asleep or something like that. Again, if it's that loud that it's causing you hearing loss, it probably is too loud for you to fall asleep. So if it's at a level where you're comfortable enough to fall asleep, most likely it's not causing damage.
Okay. A couple more questions and then one final comment. Let's see. Okay, Janet says Lions Club will help the needy get hearing aids. That's good to know. Dorrance asks, I'm profoundly deaf in one ear and hear well with the other. Would he benefit from only one hearing aid?
Yeah. So first off, what is the other ear like? And if it's perfectly normal hearing, the chances are that there would not be much effect of a hearing aid. There are sort of products out there that are made for situations like this. So for example, if my right ear is deaf or has profound hearing loss, there are ways of putting a microphone over my right ear and carrying that signal into my left ear. So I don't miss out on things that are happening on my right side, and I get more of a stereo hearing like I would. And those are called cross hearing aids because the sound's crossing over. So there are specialized solutions for a situation like that. But a lot depends on how the ear that doesn't have the profound hearing loss works. If there is even slight, mild, moderate hearing loss, the chances that you get a lot of benefit goes up.
Okay. Does Usher's syndrome cause hearing loss?
There is an association between Usher's and hearing loss. It's not, you can't predict exactly what hearing will happen, but there is quite a strong association.
Okay. And Rita says, thank you for a wonderful presentation. I have 4 hearing impaired siblings and I learned a lot today. Fortunately, they are all finally wearing hearing aids.
Awesome. That's good to hear.
Dr. Dhar, thank you so much for your time and your generosity, sharing all of this information with us. This has been so interesting, and I know the people who, there's 70 of us who've hung in till the very end, and we're all very appreciative. I will follow up with you directly to get all the URLs and all the information, and I'll send that out to everyone tonight. Thank you again, Avidor Evanston, for your support. Levy people, remember that there's a virtual concert coming up with Corky Siegel and Lynn Jordan, which should be great, right in time for the holidays, the first week in December. All the information's available on the Levy Senior Center Foundation website. Next week, we have a great presentation with Linda Garretts on her book, Redlined, and it will, hopefully it will be as interesting as it was today. Dr. Dhar, thank you so much again. This was so wonderful on so many levels.
Thanks for having me.
Okay. Have a great day, everyone. Stay safe.